Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts. Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
On this episode of The Next Breast Thing, we're joined by two renowned lactation experts, Dr. Helen Johnson and Dr. Katrina Mitchell.
How do you all start that first patient encounter? Someone comes in with lactation.
The latest version of the Academy of Breastfeeding Medicine protocol on mastitis really revolutionized.
So no antibiotics, that's blowing my mind.
I think the message to surgeons is think about this like...
So some of us don't have the luxury of catching these people early. What's the pathway if we're taking this look at it from a...
And we should no longer be doing the old school ginormous.
So what do you do in a milk fistula? I've never had one of those in my practice before.
Basically, you treat it just...
What about women who are pregnant who have a breast mass? Katrina, what's a myth you want to be busted?
Oh, man. Probably one of the easiest things we can change is...
Do cabbage leaves really work?
There's also breast milk ice cream coming out, which is not so common sense. And bathing your baby in breast milk is not common sense either. So all those wacky things that...
This is Carla,
Ellie,
Michael,
Susie,
Sitcha,
And Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country.
Inviting you to journey with us into the science of breast.
Through the heart and soul of our breast community.
from advances in procedures and patient care
to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.
Today, we're diving into one of the most essential but often overlooked topics in breast care, lactation.
For many patients, the postpartum period, especially if it's the first time around, is a time of uncertainty, discomfort, to put it mildly, and unanswered questions, especially when it comes to breast health.
We'll be covering lactation complications and even the myths that need busting, like yeast infections on the nipple.
We'll also explore the nuanced intersection between lactation and breast cancer, what it means for diagnosis and treatment, and whether breastfeeding can continue after a cancer diagnosis. This truly is a lactation conversation for everyone in the breast community, and you need to listen to this.
Fortunately, we're not in this alone. We're joined by two renowned lactation experts, Dr. Helen Johnson and Dr. Katrina Mitchell.
Dr. Helen Johnson is a breast surgical oncologist at MD Anderson Cancer Center and an international board-certified lactation consultant. She brings deep expertise in oncolactation, which is the intersection of breastfeeding and cancer. Her clinical research focuses on pregnancy-related and postpartum breast cancers.
Dr. Katrina Mitchell is a breast surgeon, lactation consultant, and perinatal mental health provider. She's a leading voice on the intersection of breastfeeding and breast cancer. She is also the creator of The Physician's Guide to Breastfeeding and author of the upcoming book, Go with the Flow, set for release in 2026 with Simon & Schuster. Helen and Katrina, welcome to the Next Breast Thing podcast.
Thank you so much for having us.
Thank you. And I'll just note that Helen came up with the title of my book.
Nice.
It's catchy. I can't wait for that. And I love The Physician's Guide to Breastfeeding. Such a great resource. So Helen, I want to start with you. Was there a moment, a patient, or an experience that shaped this path for you?
I got interested in breast surgery as a medical student, kind of by accident. I guess I wasn't expecting to even like surgery, but liked nothing else. I actually was at a program that did longitudinal clerkships in the third year, where you did half a day a week with the same physician for 6 months. And I honestly just picked a surgeon that was a woman that had children. And I asked if I could work with her. And she said, "Why do you want to be a breast surgeon?" And I said, But she took me on anyway, even though that wasn't my true motivation then. And I just fell in love immediately once we did multidisciplinary clinic and I saw all the science of tumor board, the intricate research discussions, and then the very patient-oriented clinic where people actually cared about the patient, not just the disease. Like many breastfeeding medicine physicians, I was drawn to the field because of my own personal experiences and challenges. And I realized that if I was having trouble navigating the system as someone in medicine with pretty decent breast knowledge at that point as a resident, what was it going to be like for other women? I asked on a group that I belong to called Dr. Milk, which stands for Dr. Mothers Interested in Lactation Knowledge. I asked, is there such thing as a breast surgeon that knows things about breastfeeding? Like, is this a special subfield? Someone said, there's this lady named Katrina Mitchell that knows everything about that. And that's how the rest of my career took off.
Katrina, what about you?
I am from a hippie Northern California family. Everyone was breastfed, including me. My mom talked about it when I was growing up. I did my general surgery residency at Cornell in New York City and spent my research years at our partner hospital in Tanzania. Then I was subsequently faculty with Cornell there, and I think it was really my experience living in Tanzania. It just felt like breast surgery was really the intersection of public health advocacy and women's health and surgery. This was the field for me. I knew breastfeeding was going to be important to me when I had my son, and I had him in fellowship at MD Anderson. I have to say, Henry Cure, who was our program director at the time, has remained a huge breastfeeding advocate all these years, and I still get text messages from him anytime he is traveling and sees a piece of breastfeeding art or reads something about breastfeeding. But then when I started my practice, I knew right away that I just wanted to integrate this into my surgical practice alongside breast cancer, and I think it's been a really great fit for me. Cancer can be pretty algorithmic, and it should be pretty algorithmic, but there's always something really sort of unique and interesting going on with the lactating breast and the lactating nipple. A lot of things that can happen to it.
Okay, so I am super excited both of you are here. So first of all, I didn't know this was a thing at all until I learned about it on the podcast. So I'm thrilled that you all are here to educate me and some other people. And I have felt that as a general surgeon that I'll get a patient with lactational mastitis and they've had 4 different recommendations. And I'm like, what's right? Or is this, you try this, that didn't work, we do this, some people say this. So how do you all start that first patient encounter? Someone comes in with lactational mastitis.
Can you go back even further and say, how do you diagnose lactational mastitis?
I think you bring up a really good point. There's been this complete dearth of medical attention to lactation. So the void has been filled by a lot of lay people. One person hears one piece of advice, the next person hears another piece of advice. But I think the biggest thing for surgeons, the biggest message is to diagnose this and recognize this and treat it the way we would as we would with anything else in general surgery. So we know when we're looking at a post-op seroma, that's erythema, but we know that's not infection. We know that's just fluid. Or when the radiation oncologist sends you a patient back from radiation, and we know it's just radiation skin changes, but they're concerned about an infection. So I'd say the first thing is to go back to the very basics and think about the lactating breast is very, very vascular. And so the vast majority of the time, unless someone has massaged and heated their breast and caused tissue damage, there's not going to be an infection going on. You're going to have a lot of congested blood flow in the breast because of the nature, the metabolic and vascular nature of lactation. But I'd say the first thing you want to do when you see one of these patients is say, what have you been doing? Are you pumping a lot? Are you being told to feed continuously on this breast? And to stop that in the same way that we would never feed someone with a bowel obstruction, or we never feed someone with pancreatitis. So that's the first thing. And then to just have people use as much ice as possible, just like we would post-op, and reduce all of that blood flow in the area. And then I have people do supportive measures with Tylenol or Advil as needed for systemic symptoms. But seeing mastitis nearly every single day of the year. I mean, I have a large breastfeeding clinic alongside my cancer practice. I last prescribed antibiotics probably close to 2 years ago.
Helen, is that your experience too?
Since I work at a cancer center, I don't see a lot of benign breast disease these days, but that was my experience previously, absolutely. And I think the latest version of the Academy of Breastfeeding Medicine protocol on mastitis really revolutionized the management to try to make it more evidence-based and physiologically based. Katrina and I are both co-authors on that, for full disclosure. But I think one of the earliest projects that we did together was to actually characterize lactational phlegmon as a thing that existed and kind of introduce non-surgeons in the breastfeeding medicine world to this concept of a phlegmon. And that kind of positioned phlegmon as an entity within a spectrum, much the way we think of early appendicitis, perforated appendicitis, phlegmon, abscess, the same kind of spectrum for mastitis, and really highlighting that a lot of it is inflammatory and not infectious. And one of the big goals of the protocol was to calm down the impulse to immediately prescribe antibiotics and to recognize that not all systemic symptoms are sepsis. You can have a SIRS response, if you will, just because the breast is highly metabolically active when it's lactating and hypervascular. And you can even have things like tachycardia or low-grade temperature. And this does not mean that the patient is floridly septic. They definitely don't need IV antibiotics. They definitely don't need to be in the ICU. And these things may sound kind of crazy to us as surgeons, but maybe go back to your days of residency when you got all those fun MICU consults, and you'll remember that this is not so routine for people who are non-surgeons.
We get away with that in real life. I mean, you guys are in centers, but I mean, let's face it, the easy thing for us to do is see somebody with a big red breast and we plop them on whatever, Augmentin or Keflex or whatever else, because we're not going to see them for a couple of days. If you don't put them on antibiotics, they feel like they've been undertreated. But I mean, that's the first thing that anybody does is put them on antibiotics. And you may aspirate a collection if you see it and send it for culture and you never really get anything back, which probably speaks more to what you're saying than what I'm saying. What's the sell on that, hey, we're not going to try antibiotics, and they're like, but I have an infection? How do you manage that?
That is a great question. And that is probably this cornerstone of how are we going to change this? Because this is the culture of the OBGYN world. It's the culture of the lactation world. But we know as surgeons how much we have pulled back from antibiotic overuse. And so it really is about changing the system and the messages that are being sent to patients through their OBGYNs, through their primary care providers, through the urgent cares. And I think the challenge too with surgeons, as you mentioned, is that sometimes more often than not, you are seeing someone that has gone down the road of massaging and heating. And so we all know that if we did that to the breast in general with our operations, if we did that to a pancreas, if we did that to the liver, it's bad news. And so I think the one thing you can do if you really are dealing with someone who has created some tissue damage that bacteria obviously love, you can at least tell them to stop heating their breast, stop massaging their breast, and stop pumping and overfeeding, because there's this really unfortunate false idea in lactation about the concept of milk stasis. And people think that you have a couple of ducts in your breast and they're like toothpaste and you have to squeeze them out or else you're going to end up with this raging infection. But really, milk is made and stored in the alveolar cells, and only a tablespoon or two of milk is going to sit in ducts at any one point in both of your breasts. So I do think it's challenging until we can get people to stop damaging their breasts and catch them really early, that you may be faced with having to give antibiotics. I think if you do have APP support in your clinic and someone can just lay eyes on the patient, lay hands on the patient with just a quick 10, 15-minute visit and get them on the right path, you're at least going to try to save that patient from an abscess. If you just give them antibiotics and they keep massaging, they keep heating, that's going to turn into a phlegmon and eventually it's going to coalesce into an abscess.
So no antibiotics. That's blowing my mind.
I mean, I feel like this is like a blockbuster Netflix paradigm for those of us who are old that remember checking out movies. And that this is now saying, no, don't massage, don't heat it up. And it sounds like it's a lot of education and maybe for some of us really having a short-term follow-up of being able to say, hey, trust me, but I would like you to come back in 48 hours to keep that door open. How do you all practically handle that? Or is there any other tips you can give us?
I guess for me, that is exactly how I follow people. And I also have my staff that triages and someone calls and if I'm in the OR and I may add them on later that day. Or if they're, say, okay, that's fine. I understand I should just ice and not keep massaging and not keep overfeeding. And that's where the APP support can come in too if people have really busy cancer practices and they can just get other people in their clinic to help out with the close follow-up. I think the message to surgeons is think about this like you would think about anything else as a surgeon. We understand that, for example, early antibiotics and pancreatitis worsens outcomes. And we know that pancreatitis is not necessarily a necrotizing pancreatitis from the start. And we know that we would never massage the breast. We know we would never put a heat pack on the breast after surgery. So really coming back to our roots and saying, what we've been told by the rest of the world, wait, that's not actually in a vacuum. If we were presented with this with completely clean eyes, we wouldn't approach it that way. And I think the example of taking one dose of antibiotics, there's a lot of association and not cause and effect. I think a lot of times people are feeling sort of panicky and they're feeling terrible because you do get that surge response, but it's the idea that the mind, I call it the mind-breast connection. You have an intervention going on. And also antibiotics are really anti-inflammatory too. So that's part of it as well.
Now, what about taking that a step further? So some of us don't have the luxury of catching these people early. And when they do come to us, they flat out have an abscess. What's the pathway if we're taking this look at it from a general surgery, breast surgeon standpoint? How do you deal with that? And how do you counsel with all the things that can go down that pathway?
As a surgeon, we treat these like other abscesses. They need drainage for source control. But then the question becomes, what type of drainage? And we should no longer be doing the old school ginormous incision INDs under general anesthesia, basically ever on the breast, especially in these patients. Katrina presented a really great video at ASBRS a few years ago showing how she can do a stab incision with an 11 blade, put in a hemostat to break up loculations and sticky milk, and then put in a Penrose and just have that in for a few days to keep it stented open, let everything drain out, and then take it out. I think another key point here is not all abscesses need antibiotics. If there's associated cellulitis, yes, but if it's just a pure abscess, you can get rid of all that with just draining it. Standard general surgical principles. And I think it's important to keep phlegmon on the differential. If you have office ultrasound, I think that can be really helpful to look at it yourself and see, is this a well-organized drainable fluid collection or is this an ill-defined complex fluid collection? If you're not sure, you can try an aspiration and see if you get anything, but usually you can tell pretty well from the ultrasound. And if it is a phlegmon, you do have to keep an eye on it to see if it will eventually coalesce into an abscess that does need to be drained.
I wanted to shift gears a little bit here because I had this patient in my clinic. She had been breastfeeding and then she gets diagnosed with a triple negative breast cancer. We were deciding between chemo versus upfront surgery. She ultimately decided for upfront surgery. And so I have this lactating lady that I have to take to the OR. So what would you advise me to do as the breast surgeon to make the patient's life as easy as possible, as tolerable as possible, and not create any complications during the surgery? How would you guys treat this patient?
Some of it, I think, starts with how far postpartum they are. So if they're immediately postpartum versus a year postpartum.
She was a year.
So at that point, milk production is pretty low for most people. So that's a better situation than if you have someone that was diagnosed during pregnancy or they're 4 weeks postpartum. So regardless of the time postpartum, I think it's more the time postpartum. It kind of helps you predict how much milk and downregulation you're going to be dealing with. But I usually have people start to feed a lot more off the unaffected breast to just start to downregulate the affected breast. And I've had that with melanoma cases on the breast, as well as breast cancers. And that's really just going to help decrease the hypervascularity of the breast and any fluid collections from milk. When you're talking to patients, though, I think it really is important to decrease the panic and the anxiety because, as we all know, this is an incredibly stressful experience to begin with. And then you add a new mom and a baby and lots of emotions about breastfeeding, and to just say, okay, we're going to do this operation. And when you're consenting the patient and talking about potential risks, you may be at more risk of a fluid collection if we don't get super downregulated, but it's okay. Just like a seroma, it's not going to be a problem. And even if you have a minor wound dehiscence with a potential fistula formation, that really, it's not going to be chronic. If anything, it's going to be just a small defect and you'll move on from it. And I think my most memorable case is taking out like I don't even know, probably 12 centimeter hamartoma in a lactating patient. There were a lot of different reasons why we ended up doing it. I was trying to defer it, but I was moving and she wanted it done. I said, look, this is not necessarily what I'd recommend here, but I always think of that as, as a periareolar incision. We tried to get that downregulated as much as possible. And I took out this huge mass and she actually did completely fine. Came back to me post-op, incision looked beautiful. And then 5 weeks later, a few days before I was moving, of course, she opened up a tiny little pinpoint part of the incision and did drain some milk. But that was it. I think just understanding this isn't a small bowel fistula if it does occur. It's not a pancreatic colocutaneous fistula. It's just a little bit of milk.
So what do you do in a milk fistula? I've never had one of those in my practice before.
Basically, you treat it just like you would treat any other fistula. So if you have something that is a high output short fistula, short track, then you need to get the high output downregulated. So that involves downregulating milk production if they have had a lot of high milk production. On occasion, you may need to divert the fistula with a distal drain. But Helen and I, when she was a resident, I think we looked at almost 80 procedures in my clinic between surgical procedures and biopsies and drainages of fluid collections. And the rate was less than 2%. So when I can think off of my head who those people were, they were people that had very proximal, very close to the nipple incisions that we couldn't avoid, and they had high output. And so that's where, just like any other fistula, you divert it distally with like an IR drain.
You're providing reassurance for patients as well as all of us. I'm like, I can do this when this comes in. What about women who are pregnant, who have a breast mass, and we're not going to discount them? This is new. What do we do for screening recommendations for them? Or people have back-to-back pregnancies and just haven't been able to get in for screening. What do you recommend?
We should not interrupt screening for pregnancy or lactation. There's clear guidelines from ACR, from almost every society, but we get reports all the time of women saying, I went to get my mammogram and I'm postpartum, I'm breastfeeding, or I'm pregnant, and they said I couldn't get it. Even women with high-risk mutations that really need high-risk screening. So they should be getting their screening. If you have issues, you can actually send the ACR guidelines to the radiology center, and that helps sometimes. You can give them a copy of a paper that Katrina and I wrote that's published in the Green Journal for ACOG, but this really is a myth that needs to be dispelled. So for a palpable mass, though, you should start with an ultrasound for diagnostic ultrasound for that patient. And then they should also get a mammogram as part of their workup. That should not be delayed. Thankfully, now with improved, more timely treatments, women diagnosed with breast cancer during pregnancy have the equivalent outcomes to other young women. But sadly, that's not the case for women that are diagnosed in the postpartum period. But we have a really big opportunity to help move the needle on this as breast surgeons and really spread the word and keep ordering those screening mammograms for patients to normalize getting their breast cancer screening.
Katrina, what's a myth you want to be busted? Here's your platform.
Oh, man. Along with the massage and heat of mastitis and milk fistula being this very scary thing that it is not, probably one of the easiest things we can change is the myth of yeast occurring on the nipple. If anyone's been taught anything about lactation in their breast surgery or general surgery training, it's that yeast is this problem with the nipple and, mastitis is this massage and heat situation. And it's just simply not. It's a well-vascularized epidermal surface. And I think where this yeast myth started in lactation is that people are seeing a lot of dermatitis. And dermatitis, as we all know, is very common in breast to begin with, but especially common in lactation because people are using pump contraptions and new balms and new bras. And then the baby may be touching something. An older baby may be starting solids. And, I've seen patients where the baby started eating eggs and all of a sudden the mom turns up with this itchy rash and then she's treated with all kinds of anti-yeast treatments. And then you just look at her and say, look at that pattern. It looks just like a baby's mouth. You can see where the lips are hitting. What are you allergic to that your baby is eating? So I think that's the biggest thing. I think sometimes yeast was called neuropathic pain, like the really, really terrible shooting, excruciating pain that people can get with latch. It's almost like the compression of a herniated disc and shooting sciatica pain. People get that same sort of thing with nipple stimulation in lactation at times, and that's been called yeast. With a clean slate looking at this, we would recognize that as neuropathic pain. So it'd be nice to get rid of that myth too. There's also breast milk ice cream coming out, which is not so common sense. And bathing your baby in breast milk is not common sense either. So all those wacky things, that's part of the myth busting in my book as well.
What do we do with the breastfeeding patient that is now ready for adjuvant therapy? Are they just out of luck and have to stop breastfeeding altogether, whether it's chemo or tamoxifen or even the consideration of ovarian suppression? How do you handle that?
Unfortunately, in almost all of those cases, they are not going to be able to breastfeed while on those therapies because there's either no safety data for lactation or there is reason to believe that there's transfer of these substances into milk and they can be harmful to the baby. There have been a few case reports of women pumping throughout chemo to maintain milk production, but it's mostly been for shorter courses of chemo for different cancers like lymphoma. Pumping and dumping the milk, but then trying to get the baby back to breast afterwards after enough half-lives have passed after the end of chemo. That's hard to recommend because we know these women will be immunosuppressed. We know there's risks of mastitis. We know that it could become infectious. And there's no guarantee that the baby will return to breast after being away for that long. It's a big physiologic and metabolic stress on the mom. So I would never necessarily promote that, but for women that want to try that, it has been done before and can be done with guidance from a clinical pharmacist. But for the most part, they will need to wean, and I think psychosocial support's really key there. So engaging your lactation friends and then offering them medications, because sometimes taking away that responsibility from the woman of having to do it themselves and making it like a prescribed treatment can help with a lot of those feelings. So there are medications that can be given, like cabergoline, and this can really help with the weaning process for these women.
It feels so hard to tell someone you have to stop this, to give them specific recommendations. How do you wean, especially when they're early and they have a really good milk production? Do you all have specific recommendations besides the medication?
And along those lines, do cabbage leaves really work?
No. That's another myth. So cabbage leaves carry listeria. It became an idea because they're sort of the shape of a breast, but you put them on the breast and they are wilted immediately. So you're just going to be a lot better off rotating ice packs. But cabergoline and the dosing for that is 0.5 milligrams and it's a Q72 drug. So very early postpartum, if people have a lot of milk, they probably need 3 doses. That can really, really help with the engorgement and the pain from weaning. And otherwise, I think this is a really grief-filled time and there's a lot of loss. And I really lean heavily into oncology psychology because it's hard. It's devastating to people to talk about weaning when they're not ready. But just back to the question about pumping during chemotherapy, just to add to what Helen said, that our breast cancer therapies, as we know, can be many, many months at this point. And unfortunately, we don't have a lot of information about some of our more novel therapies, immunotherapy. So I just talked to patients about the fact that we are targeting breast cells. So your milk volume will considerably decrease. We know the milk microbiome will change. So it's really kind of helping support people in making the decisions that are going to be the healthiest and the best for their cancer treatment. And there just isn't a way around it. I'd say the most pure situation where someone could theoretically keep breastfeeding uninterrupted from the unaffected breast would be like a DCIS situation that is ER negative. And so they could have surgery on the affected breast, have radiation if needed on the affected breast. They wouldn't need adjuvant endocrine therapy, and they could keep breastfeeding on the unaffected breast.
I have like 10 more questions about timing of surgery and lactation, but I'm going to limit it to one, kind of an anecdotal patient story. We were expecting to do a bilateral mastectomy shortly after delivery. And the question came up of, should she nurse for a short period of time and then wean, or just never start? So is it better not to start, or is that just a personal choice?
I think there's a lot of value to breastfeeding, even if it's just for a short period of time. That early milk is colostrum and is filled with tons of immune cells that can transfer a lot of safety and immunity to the baby that they did not get from the placenta. Even just a little bit of milk can help give them a healthy gut microbiome, decrease neck rates. So even if it's just a short period of time, I do think it's worth it. And I wanted to go back to the question about helping women who need to wean. I think there's two other things that can be helpful. One is to suggest making a keepsake. So taking nursing photos or saving some breast milk and making breast milk jewelry out of it. And then two is preserving the other breast. We send a lot of women for oncofertility consults, but then we do double mastectomies. So then maybe later they have these babies and they can't breastfeed. I think it's really important to talk about oncolactation alongside oncofertility. And if a woman is interested in potentially having another baby after she finishes treatment, she might also be interested in breastfeeding that baby. And we don't yet know if breastfeeding might reduce the risk of recurrence. We know it certainly lowers breast cancer risk in the first place. And we also know that it lowers ovarian cancer risk, even in patients with pathogenic BRCA mutations. So I think a big thing that we can do is reassure them that they can breastfeed in the future, and let's keep your healthy breast intact for that future baby that they want to have.
Thank you guys so much. This conversation has truly been incredible. Before we go, are there any final thoughts you all want to share with the breast community?
We do have our ASBRS oncolactation resource guide that we published in the past year. So that's a really good quick clinical review if you have a patient that you have on your schedule with this sort of situation with breastfeeding and breast cancer, or questions about oncofertility and in the setting of a BRCA mutation or other high-risk mutation.
If you're interested in learning more, we're also co-leading a pre-course before the next ASBRS meeting. I think it's probably too late to sign up, but hopefully it will be repeated in future years. And we'd love to continue the conversation. And one kind of last thing is, I think when you do have a patient that's breastfeeding, that's diagnosed with breast cancer, something that almost all of them want to know that they don't always ask is, have I been hurting my baby by breastfeeding them from my cancer breast? So I think it's important to just tell them that, because they might not feel comfortable asking, or they might be scared of the answer. And of course, the answer is no, you didn't transfer cancer to your baby through your breast milk. But we just need to ward that fear off and just tell them, this is not your fault. You did not hurt your baby. We're going to get you through this.
Before we go, Katrina, can you tell us about the book that's coming out next year? Where can we find it? What's it called?
My book with Simon & Schuster will be coming out next August in 2026, and it's called Go With the Flow, which I will say was Helen's title that won out of my crowdsourcing of all of my friends, and the editorial board at Simon & Schuster loved it immediately. But it's Go With the Flow, the definitive no-nonsense physician guide to breastfeeding. And it's based on my website and really based on the approach that we take as surgeons to solving problems and keeping things simple. Address a problem, intervene, resolve it, and avoid sort of the more complicated, multiple different possible recommendations that are not what we would do intuitively. It's a great opportunity, and I really think we as surgeons have so much to offer in terms of common sense in taking care of the breast.
Wonderful. Well, Helen, Katrina, thank you guys so much for being here. It's truly been an inspiration and a pleasure having you. So we really appreciate you giving us your time. Thank you very much.
Thank you.
To our listeners throughout the breast community, we're so excited you've joined us on this journey, and we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
Sitcha.
And Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.